So we'll wait for another minute before we start the session. When we talk about graft biopsy, it could be an implantation biopsy or a 0-hour biopsy. Some institutes do a surveillance or a protocol biopsy at 1 month, 3 months, depending on what the protocol they follow. By and large, I would say more than 90% of the biopsies we get are the indication biopsies. So these are all the 3 needle biopsies. Rarely implantation, we may get a wedge biopsy as an implantation biopsy. Very rarely all this ends and we get a graft nephrectomy, right? So unlike in the native kidney diseases, where I've been stressing quite a bit that the sample adequacy depends from case to case, and there is no magic number where you can say, yes, your biopsy is adequate, or no, it isn't. But for BAMF, they have given very clear criteria. We should have 2 cores of cortex, 10 non-sclerotic glomeruli, and there should be 2 arteries in the biopsy. And just like in native kidney biopsies, you have to examine all the 4 stains. There is no compromise in that. And you have to study multiple levels, just like how we study the native biopsies also. So why are they insisting on 2 cores? Because multiple studies over time have found that if you just do 1 core, there's a chance that you may miss out rejection, because we all know rejection can be a very patchy process, especially the inflammation, the tubulitis, the vasculitis, everything may not be diffusely involved. Some areas may show it and some may not. So you may miss out those positive areas, and you may miss or underreport rejection. Whereas if you do 2 cores, the chance of picking it up is 99%. And studies have showed that 10% of paired biopsy cores, that means you have 2 cores, of which only 1 core shows rejection. So this was 2-core biopsy. Both of them are looking identical. Both of them have interstitial inflammation, and both of them had tubulitis, no IFTA in both. So both were identical. So if this is the case, then you would say, oh, why did I have to take the 2nd core? But look at this other case here. On the left side is the same case with this trichrome stain. Right side is left is a silver stain, and right side is the PAS stain. So in the 2-core biopsy, the core on the right is looking normal, in the sense there's no IFTA, there's hardly any inflammation. And the other core that was sent with it, since it was a 2-core biopsy, shows more than 75% of the cortex shows a lot of inflammations. There is tubular atrophy, 3 sclerotic glomeruli here. The same thing you can see on PAS also, a closer view, absolutely normal looking, whereas on the 2nd core that was taken showed a lot of chronicity. So had only 1 core been taken, if this was the case, then only the right side core was taken, I would have called it ATI, no IFTA. Whereas see how different the 2nd core is. So when that's the reason why BAM says that you should at least have 2 cores. Okay, but having said that, again, just like in native biopsies, no tissue is discarded. We process everything, and many a time, even without any glomeruli, you can make the diagnosis of tubulitis. Though they say 2 arteries, even if you have 1 artery and it shows intimal arteritis, it's a V lesion. And you just don't need the cortex. The medulla alone is enough to identify viral nephropathies and C4D staining. So again, no tissue is wasted. You can have suboptimal biopsies that can be absolutely diagnostic also. Right, going to the first case, this is a 38-year-old male whose native kidney disease was nephropathy. So his mother was a donor, he underwent a live-related transplant. However, his creatinine over a short period of time jumped up from 1.2 to 1.8, and he had mild proteinuria, and that's when a renal biopsy was performed. Now, this is his core. There were 2 cores. The 2nd core was predominantly medulla. So I just have shown the main cortical tissue. So we have 5 glomeruli here, or 6 here. They look normal, at least at this part. You don't see any change here. The main pathology lies in the tubular interstitial compartment. Right? There's so much of blue lymphocytes all over in the interstitium. I am not sure about the tubulitis at this power, so I would like to see higher powers and I would like to see PAS stain. There is an artery here and this artery looks normal. You don't see any inflammation in the wall of the artery. So on this power, the glomeruli are okay, the vascular component is okay. It is the tubular interstitial compartment that shows the pathology. So we grade, as you know, BANF, we score each of the parameters is scored. So in this particular case, what can be scored is the interstitial inflammation. So this is how we do the grading. What percent of it is present, and depending on that, we can give a score. Here, it was extensively involved, so it was more than 50%, so it was an I3 lesion. You should make sure when you give the I score, this is again because I was asked to specifically talk about the BANF. The details of the BANF are, you should not consider the fibrotic areas. It is only the inflammation in the non-fibrotic areas. So for that, HE is not the best stain. You'll have to look at silver and trichrome, and that's why we have to do all the stains on the graft biopsy also. So we should not also assess the subcapsular cortex because there's a chance that you get inflammation there, and also perivascular. Usually there will be some amount of inflammation around the blood vessels. That should also be not considered when you're doing the eye scoring. All right. So once you've done the eye scoring, let's go closer to along with the eye, always there is a T. So before that, let's have a closer look at the glomerulus here. So just like in native, go by all the 4 compartments of the glomerular, the tubular interstitial, and the vascular. So here now a closer view, we can see the glomerulus much better on the PAS stain. It is looking normal. So now what do you look for in a graft glomerulus? You have to look for everything that you look for in the native kidney. In addition, you have to look for glomerulitis. I'll show you what it is. You have to look whether there are any fibrin thrombi within the capillaries to suggest TMA. And if it's a later biopsy on a silver stain, you definitely have to look for double contours, which suggest transplant glomerulopathy. So over and above all the features that we look for on light microscopy, these are the 3 things you have to specifically look for and mention it in your report whether it is present or not. So here we don't see any glomerulitis. I'll show you what glomerulitis is. There is no fibrin thrombi. There is, I don't want to comment on the GBM double contours, but the loops look very, very delicate, unlikely that it is showing double contours. Okay, now let's move to the main compartment, which has the inflammation. We already saw that there is interstitial inflammation, and this inflammation is lying in areas of edema. It is not in the fibrotic interstitium. That's how do you make that out? Is if it is a fibrotic interstitium, the interstitium here, the pink of the PAS would be much darker. The tubules, whenever there's interstitial fibrosis, there's associated tubular atrophy. The tubular basal membrane would be much thickened, markedly thickened, and there will be a lot of wrinkling. Here, you don't see any of that. It is just edema because of the acute process. And so this is counted as an eye lesion. It's an inflammation in a edematous interstitium. So that we anyway saw it in the previous slide. Now, this particular slide, we are assessing the tubulitis. Right? So how do you assess the tubulitis? You have to count the number of lymphocytes within each tubule. And for that, we require the PAS stain because the PAS is going to demarcate where the tubule begins and where the interstitium ends. So I will go to a closer view. The same field, I've zoomed in further. Let us take this tubule, for example. This is a longitudinally cut tubule. So how do you make out what the lymphocytes are? Because you're seeing the nuclei of the tubular epithelium also. That is also blue. The lymphocytes are also blue. So how do you differentiate it? So the lymphocytes are much smaller. So this is a lymphocyte, whereas these are all tubular epithelial cells. So you go by the size. And the lymphocytes, the blue is almost much darker. It's almost like a blackish, much more intense than the paler blue of the size of the tubular epithelium. So you go by the size size, and you go by the intensity of stain. So here, you know, in the interstitium, all these are lymphocytes. So when do you start counting as tubulitis? So take, for example, this area, right? So you have the tubular basement membrane beautifully highlighted. This is a lymphocyte because it's much smaller and much more darker as compared to the nuclei of the tubular epithelial cell. This also most likely is a lymphocyte. This is a lymphocyte, and this is a lymphocyte. Now, this one and this one are lying outside the tubular basement membrane. So we do not count this in our calculating the tubulitis score. Whereas this is crossed and this is within the tubule. So these two are counted in our total count for tubulitis. Because as you know, we need to count how many lymphocytes are there per tubulus cross-section and give it a T1, T2 or a T3 lesion. So that is why PAS becomes extremely important, because on H&E, you will never know whether this is sitting on this side of the basement membrane or it has crossed into the tubular side of the basement membrane. So whenever you look for tubulitis, make sure that it is the PAS stain slide. So this again is lymphocytes within the tubule. This is also tubulitis. Here what has happened is there's so much of inflammation, tubules, that there may probably be some breach in that also you should look for, because that signifies a T3, a severe tubulitis, when the tubular basement membrane is ruptured. Or here there are 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. 11 tubules per tubular cross section, which qualifies it as a severe tubulitis. Now, how do you count the tubules if they are cut longitudinally? The band says you don't count all of them, because then you may invariably get more than 10 in every tubule. So these are cross sections. The round area tubules are the cross sections. So this again has 1, 2, 3, 4. Oops, sorry. 1, 2, 3, 4, 5, 6, 7, 8, 9 tubules. Whereas when you have a longitudinal tubule, you have to count 10 tubular epithelial cells. And in that, assuming it's from here till here, and then you look for how many lymphocytes are there in that particular area. Okay, let's do this. This is a longitudinal area. So let's start from here. There is a lymphocyte and there's a tubular epithelial cell nucleus. So I'm just counting the tubular epithelial cell nuclei. 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. So basically from this end to this end, that's your cutoff. So now you count the lymphocytes. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, more than 12. So that's even longitudinal section is showing more than 12. So that's again a T3 lesion. So that's how you count the tubules. So this is just to show you why PAS is so important. So on the left is an H&E slide, PAS and a silver. Silver is also very good because silver also demarcates the tubular basement membrane. I don't know whether this lymphocyte is sitting in here or not, because you can't see the difference. Whereas here it's very clear, this lymphocyte is outside and it is not counted. This is just attempting to cross, still we don't count it. Whereas all these are included. Same way for the silver, this one is sitting outside. This is not counted because the tubular basement membrane is demarcated here. Whereas all these small black cells on the silver stain, they are black, much darker. I'm sure now you can make out which are the lymphocytes, the very small dots as compared to the more vesicular or a paler nuclei and larger nuclei of the tubular epithelial cell. So I hope now that's really clear about how to assess the tubulitis, and the PA stain or the silver stain are ideal because it highlights the basement membrane. So how do we grade it? So it's a graded, like I already showed you how we count it on ST1, T2, T3, depending on the number of cells. But if there is some tubular basement membrane destruction in 2 or more areas, automatically it comes as T3 if it's associated with the surrounding interstitial inflammation of an I2 and an I3, right? So again, now some tubules may have, a lot of tubules may show only T1, some may show T2, and 1 or 2 may show T3. Now band says you have to take the single most severely involved tubule. So the score is based on the highest score. If there's T3, then automatically it is T3. It is not the predominant pattern that you take, but the highest grade that is assessed for the BANF. And you should have this tubulitis at least in two different areas, one tubule in two different areas, one tubule in one area and the second tubule in another area, that is enough to call it as tubulitis. And you should not count on severely atrophic tubules. You can count on mild or moderately atrophic tubules, but if a tubule is less than 50% of its size, then you do not count that for the T score. Okay, right, so I hope that's clear. Now, along with the, so when we see I and when we see T, it's likely to be a cell-mediated rejection. Now, the third parameter that that controls or that changes the grade of a cell-mediated rejection is the vasculitis. Now, how do you assess the vasculitis? You look for these arteries. That's why BAN says you need to have at least 2 arteries, and look for any lymphocytes. Again, so now you know what lymphocytes look like, right? These very small cells. And vascular endothelial cells are these elongated cells. So the lymphocytes, even if you have 50 lymphocytes within the lumen, that does not become vasculitis. You have to see lymphocytes going under the endothelium. So this is an endothelial cell and the lymphocytes has gone beneath it. So that qualifies it as a vasculitis, and a single lymphocyte is enough to call it as a V1 lesion. So just sticking onto the surface or, adherence to this surface doesn't qualify. It has to go under the endothelium to be called as a vasculitis. Now, if it's 1 or more arteries and less than 25% of the lumen is involved, is V1. Now, if you have a V2 lesion, is here almost the entire lumen is occluded because of the severe, or I would say moderate vasculitis. You can see all the lymphocytes here going underneath the endothelium. The endothelium has got lifted up. So this is V2 lesion. And when you call it as a V3 lesion is when there is fibrinoid necrosis. Trichrome will really help you. And there is transmural inflammation. See here, the lymphocyte is just gone, just probably going into the media. Here it's just in the subintima. Whereas here it has gone through the thickness of the media almost, it's come out, right? These are all lymphocytes. So that is transmural inflammation, and here there is fibrin. This is fibrin, and if you do trichrome, that will be red. So that is a V3 lesion. So the I lesion, the T lesion, and the V lesion, them put together decides your cell-mediated rejection. Now let's go back to our patient. So this is the patient sample. We always run a control. The patient's sample for C4D by IF on fresh tissue was negative, and the positive control is working fine. So you know this is a truly negative. So it was, there was no glomerulitis. It was I2, T3. There was mild PTC1. I'll show you in the next case what PTC1 is. No vasculitis. That picture of vessels I just showed you as what is vasculitis, but our patient did not have vasculitis. There were no features of chronicity, no transplant glomerulopathy or double contouring, no interstitial fibrosis, tubular atrophy, and C4D was negative. So this is how we score. So this is, I don't think this is been there, no change has happened over quite some time, so I'm not spending too much of time. Only the 2022 modification of bans, I'm banned from, I'm going to explain more. This has been there for quite some time. So you look at, if it's T2, the minimum for it to be called as a rejection is T2 and I2. Anything that falls short of it, like it is T1 and I2 or T2 and I1, all that is goes into the borderline changes suspicious. It does not fulfill the criteria to be labeled as a cell-mediated rejection. Now, if you have vasculitis, then it goes up as a V1, V2, V3 lesion. Depending on the severity, it becomes a T2A, B, or transmural becomes a T3. Now, chronic T-cell mediated, we'll go to that later. So this is only the acute that we just saw. Now, going to the IFTA. Now, every biopsy, you need to give an IFTA scoring, because among all the markers, as I said, just like a native kidney biopsy, IFTA plays a very important role in deciding the prognosis or how is the kidney going to function long term. So, they almost always go hand in hand. Whenever there's interstitial fibrosis, there's associated tubular atrophy. It's not like you will have quite a bit of interstitial fibrosis and normal looking tubules. No, that doesn't happen. But there are some cases where there's a mild variation, in the sense you can have early interstitial fibrosis without much of tubulitis. So for that, which is quite rare, they have given the cutoff up to 5% interstitial fibrosis is considered as normal. Whereas 0, you are not supposed to see atrophic tubules. Any atrophic tubule, if you see even 1% or 2%, becomes a CT1 lesion. Whereas here, a slight leavage has been given, and up to 5%, anything above 5%, 6 to 25 onwards is mild interstitial fibrosis, mild, moderate, severe, 25 to 50, and more than 50. Both of them follow the same. So to assess IFTA, the best stains are the trichrome stain or the silver stain. Normally, you have glomeruli that look normal, blood vessel here. Some amount of fibrosis will be there around the blood vessels. That's why we are not counting the inflammation around this area also. But otherwise, the tubules are all going to be back to back in the normal appearing. In the cases of interstitial fibrosis, you're going to see much more dark blue. Edema, it'll be blue, but it'll be a much paler shade. Here you have dark, dense blue of fibrosis, and you can see the size of the tubules. They are much smaller. Atrophic, very small. They are less than half or a quarter of the size of a normal tubule, and you will see inflammation. So this is IFTA. Right? So cortical areas where tubules are not lying back to back, separated from each other, fibrous tissue, that's important. It is not by edema or inflammation, and it's best appreciated using a silver or a trichrome stain. Then the other thing that we always report on a graft biopsy is C4D. Right? We can do C4D by 2 methods. It can either be by the immunohistochemistry, or we can do by immunofluorescence. It's very important by which method you're doing, because you need to document that, because your grading is going to change, and the way you interpret it. Grading actually doesn't change, but the way you interpret the grading is going to change, because by fluorescence on fresh tissue is supposed to be more sensitive. So they've given a cutoff of up to 10% you don't consider as C4D positive if you're doing a IF, whereas if you're doing IHC on a paraffin block, then even one peritubular capillary, a single peritubular capillary with a nice circumferential linear staining is sufficient to call it as C4D positive, and it's considered as a marker for antibody-mediated rejection. So what are these peritubular capillaries? So it's easy. Normally you really don't see them. Only when they stain, they come out. Well, or always you are looking at the tubules. So these are the tubules here, and the tubular epithelium with the plump cells. These slit-like spaces between the tubules are the peritubular capillaries. Because it's stained, the wall is stained, you're seeing it really well. But otherwise, let's go back to a picture. These are the peritubular capillaries, those empty spaces. See that? So they go unnoticed because the tubules are lined by this thick epithelium. So these are all the peritubular capillaries, which now when you do the C4D and with C4D positive, they stand out very brightly. Oh, this is important. You should look at a minimum of 5 high power fields to assess C4D. So if you don't have enough tissue, if it's just a tiny bit of tissue, you don't have tissue, you may wrongly interpret it. And another thing is, especially in the early, if you're suspecting a hyperacute rejection, a graft infarct, C4D must not be scored in areas of infarction, because you may get a false negative C4D. Then again, C4D doesn't necessarily mean rejection. It can just be, it just indicates that complement fragments are there on the endothelium. That's why in ABO incompatible transplant, C4D is always positive, and it's of no diagnostic significance. So in an ABO incompatible transplant, we cannot use C4D as a parameter to assess rejection. We have to look for the other parameters, that is the glomerulitis and the peritubular capillaritis, and we have to rely heavily on the DSA also, right? So that is for the ABO incompatible. But in an otherwise graft biopsy, C4D plays a very important role as one of the features of antibody-mediated rejection. Now, case 2, we will see that it's a 28-year-old male whose father was a donor, native kidney disease was FSGS. His baseline creatinine was 1.1, which he achieved on 10th. Fever. Everything had settled. Now he's back with fever. Creatinine has gone up back to 2.2, and he had mild graft tenderness. So on probing, we found that he was not taking his medicines for almost more than a week. He said a week, but maybe probably more than that. And a renal biopsy was done. So this was his biopsy. So the two glomeruli, even on this PAR, you can see that they're very cellular. You can actually make out all the lymphocytes, the small blue cells within the lumen of the capillaries. A few neutrophils are also there. The capillary, that's why we see the capillary lumen are not patent. It doesn't look very delicate and open because of these lymphocytes. So there is glomerulitis. Interstitium is markedly edematous, and there's a lot of inflammatory infiltrate in the interstitium. I don't need a PAS stain to identify tubulitis here, because you can easily see they have crossed the tubular basement membrane, but definitely we will need that to count. But here you can see almost every alternate cell within this tubule is a lymphocyte. So there's severe tubulitis, there's severe interstitial edema and inflammation, and there is glomerulitis. There is no artery in this field, and there is peritubular capillaritis. See that? This is a peritube. Normally, peritubular capillaries are like this, very thin and delicate, or they may be even collapsed. But you see inflammatory cells in the peritubular capillaries also. So that is everything is there in this biopsy. Again, a peritubular capillaritis. Closer view to show the glomerulitis on H&E stain, and on PAS to know where exactly it is. They are all within the capillary lumen, predominantly lymphocytes, and occasional neutrophils are also there within the glomerular capillaries. So that qualifies for a glomerulitis. Now, how do you score glomerulitis? As it's like grade 1, 2, 3, depending on what percentage of glomeruli involved. That is why they say a minimum of 10 glomeruli, 10 viable glomeruli are needed. Because if you have only 2 glomeruli and both are involved, you would see, it's a G3 lesion, whereas actually if you have much more, it would probably be just a G1 lesion. So it's important more just like in native for a lupus or an IgA nephropathy classification, same here. Whenever it's a semi-quantitative assessment, you have to ensure that you have sufficient number of glomeruli. Otherwise, if it's just 2 or 3 glomeruli, please do not give a G score. So one leukocyte or one mononuclear cell is sufficient if it is occluding more than 50% of the lumen to call it as a glomerulitis. Now, if the glomerulus is partly sclerotic, or if it's collapsed, or if it's showing severe ischemic retraction and wrinkling, those glomeruli are avoided. So these are the rules of the band for how to do the glomerulitis, the G score. Same way for peritubular capillaritis, you score it depending on, just like how we count for tubulitis, there T1 is, the cutoff is 4, here it is 5, and you just look for the number of lymphocytes per tubular, so per peritubular cross section. Here again, you should see it in the cortex. You don't assess peritubular capillaritis in the medulla, because you will invariably see the lymphocytes in the vasa recta, and it will be wrongly interpreted as a PTC. So it has to be in the cortex, it should not be in the scarred areas, and it should not be in the very fibrotic areas with dense lymphocytic inflammation. So those areas to be avoided. So that is what PTC looks like. So our patient did have PTC. The next is C4D. Now you know the tubules are all normal, and whatever we saw as dilated peritubular capillaries, they were all taken up the positivity. So this is a diffuse C4D positive set. So our patient had severe glomerulitis, severe interstitial inflammation, tubulitis, peritubular capillaritis. There was no vasculitis and there were no features of chronicity. C4D was positive. So it was a combined cell-mediated and an active, it was not acute, sorry, it is active antibody-mediated rejection and acute cell-mediated rejection, BANF 1A. Now coming to, there was a question in the chat. Fibrin thrombi I couldn't see in that biopsy. And Dr. Reshma has asked, ABO incompatible transplant C4D accommodation is there? No, not only histology, that is why DSA becomes very, very important in those cases. So, because C4D, as you said, is of no use. So we always, whenever we see glomerulitis and peritubular capillaritis, we suggest that please correlate with the DSA. Okay, so for antibody-mediated rejection, here we are coming to that now. The diagnosis is based on 3 criteria. If for cell-mediated rejection, we were looking at interstitial inflammation, tubulitis, and vasculitis. Those were the 3 parameters for cell-mediated. For antibody-mediated rejection, we look for some evidence of histological evidence of antibody-mediated. That is the G and the PTC score, the glomerulitis and the peritubular capillaritis. Together, it is called microvascular inflammation. Why microvascular? Because they are all capillaries. It is not arteries or arterioles. It is capillaries. So the glomerular capillaritis and peritubular capillaritis is the microvascular inflammation, together called microvascular. That is on the biopsy. That is a histological evidence. Now the second is evidence of antibody interaction with the donor epithelium. That's what I showed you when I showed you the C4D stain. It shows that there is some antibody that is binding onto the endothelium. That is the second evidence. And the third evidence is the serology. You will have donor-specific antibodies. So all the 3 are ideally required in I'll show you that this is the area where BANF 2022 has made quite a bit of change as compared to the previous years, and we'll see what that is. So these are the 3 parameters that you have to assess for when you're looking for antibody-mediated rejection. Yeah, important of plasma cell. I think we'll go to those questions later because they're going out of the floor. Anyway, yes, plasma cell rejection is a plasma-rich rejection is documented, and they are supposed to be of a poor prognostic as compared to a cell-mediated rejection. They don't resolve as well as a cell-mediated rejection. We definitely, if there is a predominance of more than 10% of plasma cells, then we definitely specifically mention that. Also, before jumping and calling it as a plasma cell rejection, whenever you see plasma cells in the interstitium in a graft biopsy, always think of the possibility of a viral infection. Because we rule out, we have to do CMV and DKV, and if required, adeno, and then make sure that there is no viral nephropathy before calling it as a plasma cell rich rejection. Yes, Dr. Renu, absolutely, I absolutely agree with you. C4D persists sometimes, yes, it is very difficult. So we go by the microvascular inflammation. C4D remains there. Yes, Dr. Reshma has asked, ma'am, does hemorrhage in PTC indicate ABMR? As of now, hemorrhage in the interstitium earlier, when BANF, I think in the 90s and the 2000, interstitial hemorrhage was one of the features of rejection. But now it is not included in the BANF scoring. MVI being mentioned. Now, what is MVI? It is a combination of the G and the PTC score. The threshold value to define ABMR is 2 or more. The combined G and PTC together should be 2 or more. Just isolated PTC without G and without C4D is not specific for antibody-mediated rejection. The current rule is to ignore or discount isolated PTC without G in the presence of features of borderline T-cell mediated rejection or T-cell mediated rejection. So it is, see, when in a cell-mediated rejection, you saw the amount of interstitial inflammation there in the interstitium. So it's bound to have peritubular capillaritis too there. So when you see no evidence, no C4D, no glomerulitis, but you see only PTC and there is cell-mediated rejection, those inflammatory cells in the peritubular capillaries are most likely because of the cell-mediated rejection and not of the antibody-mediated rejection. So this is a very important point that the 2022 BANF has highlighted. Isolated PTC should not be considered as a feature of antibody-mediated. But if you have glomerulitis also, then it definitely becomes significant. So this is, if you have one slide for you to remember the changes in the BANF 2022, this is it. So for antibody-mediated rejection, these are all the parameters that they've used. The CG and the PTCML are for the chronicity, that is a transplant glomerulopathy and peritubular capillary multilayering. And TMA can be a feature of antibody-mediated rejection. So all these 6 parameters are all associated with antibody-mediated rejection. But mostly now we will be talking about the microvascular inflammation. Let us ignore these for the time being because these are more for the chronic antibody-mediated rejection. Let's just look at the G and the PTC. So you evaluate. You have first step is you give a G score and a PTC score. Now, if your G and PTC score together, they add up to or more, then what do? First, you look for the C4D. If C4D is positive versus C4D is negative, right? So here you have a PTC MVI more than 2. But here it's an MVI less than 2. We will look at all the conditions where you have MVI more than 2. Now, MVI more than 2, you can have C4D positive or C4D negative, right? So you have MVI, the first possibility is MVI is there, C4D is there, positive, and DSA is positive. Straight away, all the 3 parameters have met for antibody-mediated rejection. So BANF 2019 also called it antibody. So this is like, without a doubt, you don't have to think twice. There's peritubular capillaritis, glomerulitis, C4D positive, DSA positive. Yes, all the boxes are ticked. ABMR earlier also, and now it stays good. Second possibility, there is peritubular capillaritis. Either C4D is positive or DSA. Both are not positive. One is positive, one is negative. It is still antibody-mediated rejection. So you have microvascular inflammation and C4D positive, DSA negative. It is ABMR, or microvascular inflammation, C4D negative, but DSA positive, it is still ABMR. It was like that in 2019, even now it remains the same. Now the new term thing that has come up, the new subtype of AMR, one is the microvascular inflammation, DSA negative, C4D negative. That's the terminology that they've used. So this has been recently added on. So this is a condition where you have significant microvascular inflammation, but C4D is negative, DSA is also negative. So up to 2019, such cases, we did not call them ABMR. It was some would call it suspicious of ABMR, but it was not labeled as antibody-mediated rejection. But now they have given a lot of significance to this microvascular inflammation, and they do not want to ignore it or just brush it aside as it's not part of ABMR. Instead, they have added it into a new group, and now the BANF 2024, by then now they are studying all these cases, and I'm sure 2024 will come up with some definitive opinion on how to go about such cases. So now this is a new category. The microvascular inflammation alone, without DSA, without C4D, is still now considered a part of antibody-mediated rejection in 2022. Okay, so that is a new one in 2022. Now let's go to the other half. That is, there are diagnostic features of microvascular inflammation, but it doesn't add up to 2 or more. That must be just G1 or PTC1, either of the 2. Then again, every case you evaluate, right, for C4D. Now, if C4D is positive and you have just G1 and PTC0 or G0 and PTC1, either way, but C4D is positive, whether DSA is positive or not, it is irrelevant. It is still an antibody-mediated rejection in 2019 and also in 2022. So there is no change. So one of the parameters with C4D positive is antibody-mediated rejection. Now, the same, you have mild or G1, no PTC, C4D is negative, but DSA is positive. Earlier, we called it as no antibody-mediated rejection, but now the new terminology for this is probable antibody-mediated rejection. This is the other new term. When there is DSA positivity, C4D is negative, and you have either G1 or PTC1. Right, I think in 2017 or 2015, the C4D negative ABMR came out to be in a, that is when a lot of, for the first time, they brought out the rule that you can have antibody-mediated rejection, which is C4D negative, 2017 or 2015, I'm not sure. But now over time, now that's quite well established that you can very well have C4D negative and still have a ABMR. So now, with just mild microvascular inflammation and with C4D negative, now the new subgroup of ABMR is a probable ABMR, right? Then the third option is you have just either G1 or PTC1, but no C4D, no DSA. In that case, you do not call it as an ABMR. That was how the earlier change was. So these are the two conditions where you have a new subclassification of BANF 2022. Let's see what BANF 2024 will come out next year. Okay, so that was about ABMR and ACR. Dr. Megha, does PTC seen normally? Peritubular capillaries are normally seen. Like in every part, you look for it, they'll be just slit-like spaces. So in every, even in, it is there, right? Because that's the, just study, remember the histology of your glomerulus, the nephron, the descending tubule, the ascending tubule. You have a rich network of capillaries around it. Those are the peritubular capillaries. So it's always there. It is just that you will have a lot of inflammatory cells in the peritubular capillaries. Now, the third case is a 35-year-old patient. Donor was his wife. Native kidney disease was not known. Baseline creatinine was 1. 4 months later, creatinine jumped up to 1.8 with some proteinuria and a biopsy was done. So here I've just put the tubular interstitial compartment, the glomeruli were normal. Tubules are back to back, no interstitial fibrosis, no atrophic tubules, no interstitial inflammation. I don't see tubulitis. The pathology is in the tubular epithelial cells. Markedly swollen with cytoplasmic vacuole. So this is one tubule with very, very, ballooned out tubules, and these tubules are filled with these small vacuoles, which are almost equal in size, or what we call as isometric vacuoles. And here this patient IF was negative, C4D was negative. So this was acute tubular injury. You can see the sloughed off degenerated epithelial cells here. So we gave diagnosis was ATI with a possibility that it's due to acute calcineurin inhibitor toxicity. There was no evidence of rejection. Now, the moment or anybody talks about CNI toxicity, and the thing that crosses your mind is isometric vacuoles. But you need to remember that isometric vacuoles by itself is not diagnostic of CNI toxicity. You can get isometric vacuoles even due to any other cause for rejection, or for tubular injury. If there's proteinuria, if there's significant proteinuria, if there's recurrence of FSGS, also you will see this isometric vacuole. So that alone, you cannot use it as a diagnostic criteria for CNI toxicity. But if you see this single myocyte necrosis also in the arterioles, so basically this is a small vessel. These are the myocytes or the smooth muscle cells. That's how all of them should be. But you can see these empty holes. These are basically the smooth muscle cells that have undergone necrosis. So that leaves an empty space, or vacuolization or dropout. It's called a dropout necrosis. That is a feature, or that is also a feature of CNI toxicity. So when you see both together, no rejection, and then the probability of it being a CNI toxicity is higher. And sometimes you may see a severe form of CNI toxicity where you have fibrin also within the arterioles and the glomerular capillaries. That, ruling out all other causes of TMA, that also adds on to CNI toxicity. So these are the three features of acute CNI toxicity, from the mildest to the most severe form. Each one by itself is not diagnostic, but combining them with ruling out other possibilities, that is how we come to a conclusion, or we don't give a clear diagnosis of CNI toxicity on a biopsy. We always suggest it. It's ATI suggestive of CNI toxicity. Now, over time, the single myocyte necrosis that was there, hyaline gets deposited there. So since it was just nodular, the hyaline will take up the empty spaces. So you'll have a nodular arteriolar hyalinosis. Like a string of pearls or whatever it is described. So this nodular arteriolar hyalinosis again is suggestive of a chronic CNI toxicity, as compared to if the hyaline was like a thick band, diffusely thickened, then it's non-specific hypertension or any other condition of hyalinosis, diabetes, all that will have a very uniform thickness. Whereas here you can see thin and thick areas to suggest chronic CNI toxicity. And the other feature, just like isometric vacuoles, you may the next thing that comes in your mind is striped fibrosis. But that's what is striped fibrosis. You have one band of fibrosis, then you have normal tubules. So it's best seen in a trichrome stain because of the contrast between the blue and the red. And band of fibrosis with normal, then again a band of fibrosis. But again, this alone is not diagnostic. It could be seen in any condition leading to chronic interstitial fibrosis. So you have to correlate with the other findings to call something as chronic CNI toxicity. All right. Now, earlier in the 2019, up to 2019, acute tubular injury was considered as a possibility of it being of antibody-mediated rejection. But now 2022 has removed the ATI pattern of antibody-mediated rejection. When do you get that? There are three possibilities when you can get this ATI with associated with antibody-mediated. That is, you can have ATI, it can be C4D positive, DSA positive. In that case, it is straightforward with a positive cross match, but there's no microvascular inflammation. ATI, C4D is positive, and in an ABO incompatible transplant, it is of no value. Whereas ATI, C4D positive in a conventional transplant patient, but DSA negative or positive, that is the third situation where you can see an ATI-like pictures. So what does the 2022 band say? Cases with ATI alone and C4D positive should be reported descriptively. You don't straight away call just because it's C4D is positive and ATI. Earlier, 2019, we used to call them as ABMR. But now 2022 says that if you have just ATI and C4D positivity, you should just give a descriptive thing and comment about, what could be the possibility. It suggests with a positive cross match, it is likely to be antibody-mediated rejection. Or if it's an AB incompatible or a conventional, then the whole scenario changes. So just because ATI is there and C4D is positive, that criteria has been ruled out. You will have to give a descriptive report in such a case. So this is another field where they are doing more. So again, 2024 may come up with something more to this ATI part also. Right? So let us go to case 4. This is a 16-year-old male, live-related transplant, mother donor, native kidney disease was reflux nephropathy. Creatinine was 2.1 on his 14th post-transplant day. TMA, right? Fibrin within the glomerular capillaries, confirmed on trichrome stain. And the other areas showed, this is I'm zoomed up, okay? These are tubules. This is an arteriole showing single myocyte necrosis. This was a thrombotic microangiopathy. Now, what are the causes of TMA in an allograft? You could have all of these. Anything that causes TMA in the native kidney can also cause TMA in the graft. In addition, you should think of the first three possibilities. I've just written atypical HUS, but anything that causes TMA in the native kidney, the list, add that. Along with that, these are the three other causes or main important causes in a graft, that is immunosuppressive agents, especially calcineurin. In our population, the most common cause of TMA in our patients is CNI toxicity. The next is antibody-mediated rejection and infection, especially CMV, is known to cause TMA. So whenever you see a TMA, think of all the causes, and by exclusion, like if it's C4D, you look at the C4D status, you look at the DSA status, and decide whether what it possibly could be, do the viral markers. And like in this particular patient, we had the single myocyte necrosis also, the stack level was high, so everything fitted it into TMA due to CNI toxicity. So again, just light microscopy alone may not be able to tell you what is the cause of TMA. TMA can be easily diagnosed just on light microscopy, but you will need additional parameters to probably conclude on what is the cause of TMA. Now, the next feature after TMA is we come to transplant glomerulopathy. That is all this while we were talking about the acute parameters. Now, the TG lesion or the transplant glomerulopathy is a hallmark of a chronic rejection process, a chronic endothelial injury. So, the main pathological feature, the light microscopic feature, is GBM duplication and the absence of immune complex. That's most important. We have to underline the absence of immune complex. Now, if you remember the MPGN class, we talked about MPGN being divided into three. One is MPGN could be immune complex mediated, or MPGN could be complement mediated. And the third classification of MPGN is without immune complexes, without complement. That under that category, you will have transplant glomerulopathy, you have chronic TMA, malignant hypertension. Those are the conditions. So light microscopically, it has MPGN pattern because there's GBM duplication, and usually there's some mesangial hypercellularity, though it may not be there, but GBM duplication is required to call something as transplant glomerulopathy. And you have to prove by IF that there are no immune complexes. Otherwise, it could very well be a recurrence of a native kidney disease or a de novo MPGN. So how do you differentiate transplant glomerulopathy from recurrent MPGN immune complex mediated or recurrent MPGN due to hepatitis? How do you differentiate it? It is by IF, because IF will be negative in transplant glomerulopathy, whereas it will be positive in their other conditions, right? So this is how it looks like. A typical MPGN pattern, you may have the lobular accentuation, double contours. In this particular case, it was an ongoing process, so you had glomerulitis also. And silver stain shows the beautiful double contouring of the GBM, which is required to call something as TG. Now, how do you grade it? It has got a lot of subdivisions. Basically, the CG1A is a diagnosis that is made only by EM, but the rest we start making it from by light microscopy only, depending. And here, unlike glomerulitis, in glomerulitis, you look at all the glomeruli and what percentage of glomeruli or number of glomeruli are involved, that is a G score. Whereas in transplant glomerulopathy, it's not like that. You look at all the glomeruli, then you pick out the most severely involved glomerulus. Then your grading is based only on that most severe glomerulus. You take, like, I checked the entire field and I found that this is the most severe glomerulus. Now you ignore all the other glomeruli, and this particular glomerulus, you look whether the double contours is seen in more than 50% of the capillaries, or is it 25 to 50%, or it is just 1 to 25% based on that. You can see, I would say it is nearly 35%. These are the areas. So 50% would be half. It's not there in some of these areas. It is definitely more than 1/4. So around 30, I would call it as a CG2 lesion. So go to all the fields, pick out the most severely involved one, and then in that severely involved one, assess what percentage of the capillary is showing. So that is how you do the TG score. Now, the earliest lesion, CG1A, as I said, on light microscopy, it looks absolutely normal. There may be tubular glomerulitis, but there is no double contouring. But EM picks up the earliest stage, that is the subendothelial lucent widening. So the normal, so this is one capillary loop, RBC here, the mesangium here, the podocytes here, the GBM here. So this is the endothelium. Now the endothelium has got lifted up, right? And there's some edema here, the paler substance. So this is called the subendothelial lucent widening. And this is the earliest lesion which is picked up only on EM. So now EM has certain, thankfully BANF has not included EM as a definitive tool to assess because they've taken into consideration the entire world. But EM, this is one condition where you do require EM. That is the earliest transplant glomerulopathy lesion, CG1A. Then the peritubular multilayering, that's another condition where you need EM to identify it. And of course, you look for if it's an early FSGS, food process effacement, because it takes few days to weeks for the segmental scarring to be seen, whereas you may have proteinuria within hours of transplant. You are never, even if you have 100 glomeruli, you are never going to see FSGS on day one post-transplant. It is going to take some days for the synechiae and the collagen to be laid down. But EM at even 1 or 2 hours after transplant, the moment the proteinuria has set in, you do an EM, you will be able to see the food process effacement. So that's another criteria. Another use of EM, and of course to identify certain recurrent or de novo glomerular diseases. So this is an advanced stage of CG lesion. Here double contours, like I showed you a similar picture where in MPGN, like the original GBM, then in that particular case, it was immune deficit. So the homogeneous gray, whereas here there are no immune deficits. Here what they call is mesangial interposition. The mesangium sort of tries to grow, because why is this happening? This is happening because of recurrent endothelial injury. So as a process of repair, it is the mesangial cell that goes here and there to repair the glomerulus, right? So the mesangium comes to the aid of the endothelium. It sort of stretches out and comes out into this area to contain or to help out the endothelium. So you will have mesangial cells. You can actually see, this is actually a glomerular capillary. The mesangium was here, but the mesangial cell has extended into between the two layers. So that is what you're seeing here, the nucleus of a mesangial cell. This is the new basal membrane that is being formed, and you can see how small the lumen has become. This was the original GBM. But you will not see immune deposits. So if IF would have picked it up, in case you have a doubt, look at EM. EM will not show electron dense deposits. So it's not an MPGN recurrence or a de novo immune complex or complement mediated. Because it's very important, because dense deposit disease can look like this, and 100% recurrence is known for dense deposit disease. So you'll have to differentiate dense deposit disease, the MPGN pattern, because of that, from a TG lesion. Do the IF. IF will help you. If at all you are having a doubt, EM is definitely going to help you with the diagnosis. Now, what about chronic TMA versus TG? Because chronic TMA can also show double contours. How do you differentiate chronic TMA from transplant glomerulopathy? To be honest, there is no definite ultrastructural or light microscopic criteria to distinguish chronic TMA from transplant glomerulopathy. So even EM has failed here to differentiate. You will have to go for the clinical history for, there should be early biopsy proven antibody mediated rejection. Then it's likely that it is a chronic antibody mediated rejection and a TMA, or it's like if it is the native kidney disease was TMA and there is a recurrence, or the patient had a high CNI toxicity for a long time. So clinical history will be very important to differentiate these two, because this is a situation where EM also will not be able to differentiate it. So transplant glomerulopathy, again, it could be because of chronic antibody-mediated rejection, hepatitis C infection, though you will see some immune deficits there, and TMA, they all overlap, especially in an advanced stage of injury. So chronic now this was about acute. Now let's go to chronic antibody-mediated rejection. That's what we saw, this TG lesion. what are the evidences? One is transplant glomerulopathy, what we just saw, double contouring. The second is peritubular basal membrane multilayering. This is the other condition where you require EM, and arterial intimal fibrosis of new onset. Now, to call something as new onset, they should definitely have had a previous biopsy. You can never identify this on the first biopsy. Right? You should prove that this intimal fibrosis was not there and now it has developed. Now, this is again a controversial thing, and 2022 has been actively, trying to dissuade this particular pattern. So let's see, 2024 will give us a better clarity on this. So what is peritubular capillary basal membrane multilayering? Now this is, somebody had asked, do you normally see peritubular capillaries? Yes, this is how you look. You look for it, you look properly, you will see between the tubules slit-like spaces, normal. This is on EM. This is what a normal peritubular capillary looks. This is a proximal tubule with all the organelles in it. This is another proximal tubule, and this is the basal membrane of the tubular epithelium. Between them, a delicate, almost a single layer, a very, very thin peritubular basal membrane, and the endothelium is so thin and stretched out. Only in multiple levels will you see the cytoplasm, the nucleus of the endothelium. This is only the cytoplasm of the endothelium that you see. Now, on the extreme right is again a peritubular basal membrane, and this is an inflammatory cell here. Now, instead of a single layer, you have 1, 2, 3, 4, 5, 6, more than 10, 12 layers of basal membrane. Again, just like a TG or a transplant glomerulopathy or a CG lesion, because of repeated endothelial injury, as a part of healing, new basal membrane is being laid down as a healing process to the injured endothelium. So that is how you see it. This is a feature that can be identified only on EM, and you have to count it. And what is significant is, it is significant only if there's more than 7 layers in one PTC or more than 5 layers in 2 PTC. These mild and moderate are not considered a part of a chronic antibody-mediated rejection. You can see this in any lot of other conditions, a mild and moderate. The severe form of PTC alone is associated with a chronic active antibody-mediated rejection. Now, case 4 is a 38-year-old male who underwent a renal transplant 4 years ago. He had a biopsy-proven acute cell-mediated rejection 1A a year ago. Now his creatinine has gone up to 3.5. What does this show? 2 glomeruli on HNE, the same section I put on PA stain, so it's a deeper level. In addition, now one viable glomerulus has popped up, but predominantly a lot of chronicity, a lot of interstitial fibrosis here, a lot of lymphocytes, in fact forming a lymphoid aggregate here, and look at the blood vessels, severe arteriosclerosis. But there is some inflammation here, there is possibly some tubulitis. Let's take a closer look. So on low power, you're seeing predominantly chronic lesions here of glomerular sclerosis. Yes, this glomerulus is here. You can see it, and deeper level is much better visible. A lot of IFTA, severe arteriosclerosis, a lot of inflammation, and the inflammation is predominantly in the areas of fibrosis. HNE here, segmentally sclerotic glomerulus, inflammation in the fibrotic areas, lot of inflammation, interstitial fibrosis, the blue areas, and a lot of inflammatory cells in the blue areas. So what is IFTA? I-IFTA. IFTA we already saw, the CI and the CT score. What is I-IFTA? I-IFTA is inflammation in the areas of interstitial fibrosis. So it's considered as a consequence of an active T-cell mediated rejection. So somewhere between undergoing complete fibrosis and between a cell-mediated rejection, the in-between stage is when you still have inflammation and you have fibrosis. So if left untreated, this will progress to irreversible fibrosis and scarring of the glomerulus. So I-IFTA is graded as 1, 2, 3, again, based on how much of inflammation. In up to 10%, you ignore it, 10 to 25, 25 to 50, and more than 50 of inflammation in inflammatory cells in the areas of interstitial fibrosis. Now, how is this different from the I score? The I score is counting or is assessing inflammation only in the non-fibrotic fibrotic score. Whereas IFTA, it is exactly the opposite. IFTA is assessing the inflammation only in the fibrotic area. So you have one glomerulus, one core, 70% of it is normal. Normal in the sense there is no IFTA. So I score is assessed in that 70% area where there is no fibrosis. The 30% area is fibrotic, and you assess IFTA in that 30% alone. You are not looking at the normal area at all when you give a score for IFTA. The reverse for I score, right? So I hope that's clear. Now, okay, we identified IFTA. Another thing that you have to look for in IFTA is the T-IFTA. So just like it is tubulitis in the areas of interstitial fibrosis. Our T score for acute cell-mediated rejection, again, we said we should not look at areas of fibrosis. Here, totally opposite, you are looking at the areas of fibrosis. So this is a scarred area, a closer view, and you can see lymphocytes, multiple lymphocytes here in the irregularly thickened and wrinkled atrophic tubule. Now, this atrophic tubule is not severely atrophic. I would just call it moderate atrophy. Severe atrophy would be really small, shrunken, shriveled up tubule. In those cases, like something like this. This you don't assess. But these are tubules in the atrophic areas. And you can see these small black dots are the lymphocytes. And this is the T-IFTA. So you have I-IFTA and T-IFTA. So again, you grade just like how you grade the T score, 1 to 4, 5 to 10, more than 10. That's how you do the T-IFTA score. So this is the 2022 recommendation, scoring of tubulitis in the areas of interstitial fibrosis, right? So it is graded according to the presence of mononuclear cells in the non-atrophic, mildly atrophic or moderately atrophic tubules in the area of interstitial fibrosis. So just look at the area of interstitial fibrosis, and there you look for the T-IFTA score. But if it's severely atrophic tubules, those tubules alone are not considered. Right? So I hope that's like really clear now. So now we come to the chronic active cell-mediated rejection. Now, when we talked about acute cell-mediated rejection, it was the I score, the T score, and the V score that we were considering. Now, for chronic active mediated rejection, it is the I-IFTA and the T-IFTA and the CV score that we are taking into consideration. So just like there too, you have to have a minimum of a score 2. Here also, depending on whether it's a 2 or 3 and how much is the IFTA and the severity of tubulitis, it is graded as 1A, 1B. Now, if you have a chronic allograft arteriopathy with severe interstitial fibrosis with inflammatory cells, it becomes a grade 2. Just like how vasculitis made it a grade 2, here the vascular component makes it a more severe or a higher grade. Right? So that was about the BANF. Now, I spoke about acute cell-mediated rejection, active. Now it's not acute, remember. It is active antibody-mediated rejection and the chronic cell-mediated and antibody-mediated rejection. Now, another major portion of graft biopsies is the infections in the graft. Now, this is something probably all of you know, and the time frame where different types of infection comes depends on the the status of immunosuppression. When the first year where it's severely immunosuppressed, you have the maximum amount of infection. The immediate post-op transplant is usually a nosocomial or technical because of surgical, all the catheters and tubes. And over the course of time, you have different diseases, like if you have a chronic viral infection and you can have viral oncogenesis. So all this depending on the period of time and also the status of your immunosuppression that will give certain particular, the patient most susceptible. BKV is most common, then CMV and adeno. How do they look like? BKV is easily identifiable with this pale ground glass like intranuclear inclusion. CMV, as the name suggests, is cytomegalo. The cell is much bigger, double or 3 or 4 times the size of normal tubular epithelial cell. And you will have this reddish intranuclear inclusion. and you will have granular cytoplasmic inclusion. BKV does not have cytoplasmic, it only has a nuclear inclusion. And adenovirus can be easily mistaken as a pyelonephritis, because clinically also they present as with fever, graft tenderness, hematuria, pyuria, all those features of typical pyelonephritis. And the biopsy also looks like pyelonephritis, because you'll have a lot of inflammatory cells, karyorectic debris, tubular necrosis, ill-defined granulomas. But if you look carefully, you will see these ground glass or a hazy intranuclear inclusions, and we have to do a IHC to confirm the diagnosis. So for BKV or all the viruses we identify by IHC, we don't resort to EM because it's more cumbersome, and when you have IHC within the same day you get, and it's more accurate. EM is looking at only a few tubules. There's a greater chance missing out on the viral inclusions, whereas in IHC the entire tissue is examined. And the band 2019 had come up with the PVN scoring system. So PVN scoring system takes into two parameters. One, it assesses what percentage or how much of how many cells are positive on IHC. That is one score, the PVL score, and it also takes into consideration the amount of interstitial inflammation and interstitial fibrosis, the CI score. So you combine the CI score with the PVL score together to give the PVN score. And this is cytomegalovirus here with the positive, and adenovirus, which can just look just like pyelonephritis. You may easily mistake this for pus cell CAS, and clinically also it fits in, but always be careful. Whenever you see pyelonephritis, always rule out the possibility of an adenovirus infection. So those were viral and bacterial infections. Graft pyelonephritis is not rare at all. You may have mycobacterial infection, especially you may have a necrotizing granulomatous inflammation because the patient is severely immunosuppressed. You may even see acid-fast bacilli. Normally in a native kidney with tuberculous pyelonephritis, you hardly see any acid-fast bacilli on staining, whereas in an immunosuppressed, in a post-transplant patient, you can here and there see acid-fast bacilli. Now, what about the fungal infections? Mucor, Aspergillus, Candida, and Cryptococcus, they are the most common. The Aspergillus is most common, and you can see it in the immediate post-transplant period. They present with a very catastrophic, the anastomosis gives way and the patient goes into a shock. So think of Mucor or Aspergillus because they are angioinvasive and they have propensity to destroy very quickly the vasculature and cause severe hemorrhage and shock. Candida is quite common, and rarely we can see Cryptococcus within the tubule, in the kidney. It's not just, we have thunder and lightning going on here, right? So I think, yes, we are on time.